Welcome to Off the Chart with Medical Economics, a podcast featuring lively and informative conversations with healthcare experts, opinion leaders, and practicing physicians about the challenges facing doctors in medical practices today. I'm Jeff Bendix, Senior Editor of Medical Economics. The usual image of a mental health professional is someone like a psychiatrist or a social worker. But in reality, most Americans seeking mental or behavioral health treatment get it from their primary care doctor. About 40% of office visits for mental health issues take place in primary care offices, and primary care doctors write nearly half of all prescriptions for treating a mental illness. But with 1 in 5 adults experiencing some form of mental or behavioral health issue every year, PCPs are finding it harder to keep up with the demand for treatment. One way to meet the demand is by integrating behavioral health and primary care services. My guest today has long experience with behavioral health integration. She is Mary Gabriel, MD, lead for collaborative care at University Hospital Health System in Cleveland. UHHS provides all its primary care practices with access to behavioral health specialists, either in person or virtually. She's here to talk about how UHHS has done this and the benefits that come from joining primary care and behavioral health. I'd like to start by asking you what are some of the clinical benefits of bringing behavioral health services into a primary care practice?
So there are benefits on multiple levels, like benefits for patients in that, a lot of patients would prefer to get their health care at their primary care office. Unfortunately, mental health still carries significant stigma. And it's much more palatable for a lot of people to walk into their PCP's office than to walk into a community mental health center or a psychiatrist or therapist's office. Just something that's a bit more familiar and comforting and just not quite as feeling as judgmental, when you walk into your primary office. So that's one thing. I think another thing is that because collaborative care specifically, integrated care in general, because they are identifying, for the most part, mental illness or mental health issues earlier in the course of disease, really sort of when things are emerging, if their primary care providers are prevailing for these issues, is that you identify them sooner so that you intervene sooner, preventing worsening and escalation of symptoms and the sequelae that comes from more moderate to severe disease. And then two, you impact that patient's trajectory, especially in, if you look at pediatric collaborative care, children, they're developing. And so the longer they sit with a mental health issue or illness, it greatly impacts their outcomes into adulthood. So, and it's true with adults as well. The brain, we continue developing until the age of 25. So even young adults can have long-term sequelae from untreated mental health issues. There are also pretty significant economic impacts from integrating mental health care into primary care. Again, if you identify early on, you are less likely to use higher level and more tertiary level of service, less severe and acute types of service such as crisis interventions, emergency room visits, inpatient hospitalizations, things like that really are a pretty significant burden to healthcare economy.
Are there studies showing that?
Oh, yes. So I think so far there are last count I saw, over 90 randomized controlled trials looking at collaborative care, looking at all kinds of outcomes, not only clinical benefit, but also sustainability and sort of economic benefit. And this has demonstrated that. You have less utilization of higher levels of care, and so that keeps costs down. I think the other really good place to look for any kind of information on collaborative care is University of Washington AIMS Center website. That is all collaborative care. It is a repository / clearinghouse of all things collaborative care, including data, studies, and long-term benefits of the model. Actually, this is where collaborative care originated. The very first model, which was created back in the 90s, was there at the University of Washington, and they have developed this entire sort of network and institute based around collaborative care.
How is integration accomplished in a university hospital system?
So we have multiple forms of integration. I think it depends on what kind of care you're looking at. So before the integration of mental health care, meaning having some sort of mental health provider directly engaging clinically with patients in a primary care setting, we have ways of primary care physicians and specialty physicians actually to engage with mental health providers in sort of asynchronous ways. So one of the things that we provide, we have developed clinical practice guidelines for all primary care providers, both adult and pediatric. And those include really the three big disorders that most primary care physicians will be taking care of within their practice. And that includes anxiety, depression, and ADHD. Certainly mental health goes beyond those things, but the predominance of complaints that patients come to seeking care from their PCP for mental health issues typically falls in those three buckets. So there are these clinical practice guidelines that offer coaching, guidance, algorithms, information, data, and recommendations for how to manage any of those disorders. Then in addition to that, we have something called e-consults through our electronic health record. And so a PCP or a specialist can put in a request for an e-consult. They enter the patient's basic information, the disorder, what they've done so far, what the outcomes are, what their question is. Usually they're asking, what should I do next? Or I've already tried these things. What are your thoughts? And so what we will do, we have a pool of psychiatrists that gets each of these consults and reviews the chart. And then we'll respond with recommendations. And so this has now saved a visit with a psychiatrist or a therapist. It has given the PCP some guidance and recommendations almost in real time, sometimes at point of care. And it hastens treatment to these patients in a much more efficient way. Whereas, making a referral, waiting for that appointment to be made, waiting for the appointment to then come can sometimes take, at least 2 weeks as far as like our consult clinic goes. So that saves a lot of time and can give some really good sort of informed, clinically relevant and evidence-based advice.
I'm not clear who is actually providing the care, though, at this point. Is it still the PCP who is doing the counseling?
Yes.
with the input of this pool of psychiatrists?
Right. So
Okay.
The PCPs, they won't typically do a whole lot of counseling. This is more sort of medication management.
Okay.
There will be recommendations for types of therapy if that's part of the recommendation or if that seems appropriate. But all of these things are in place even before there's any sort of direct integration. So on top of that, we also have various forms of integrated care at UH, ranging anywhere from co-located clinics within a primary care setting or even a specialty care setting, all the way up to true collaborative care. So with the co-located clinics, we will have a psychiatrist or a psychologist who is embedded within a and they sort of hold their own clinic within the practice. So it takes barriers down in that they're not necessarily, I guess, geographically siloed, but it's still sort of siloed in that the specialist is taking care of their patients, the primary care person is taking care of their patients, even though they are referring. The next step to that is sort of shared care in that there is some communication, but the PCP is still not primarily responsible for this patient's mental health care. And then further on down the continuum is true sort of integrated care. And that care can be based on a couple of different models, one of which is collaborative care. Another one is the primary care behavioral health model. The collaborative care model is structured such that there is an embedded mental health worker. So that is typically a licensed clinical social worker or a licensed professional counselor. So people who are therapists in their own right, who are embedded in a primary care setting, and they become part of the primary care team. And so this person works closely with the PCP, and they share the care of this patient with the PCP. So in addition to this mental health worker managing these patients and coordinating their care, as well as offering brief psychotherapeutic interventions, they also consult with a psychiatrist. Every referral, every new patient that is added to a caseload for this mental health worker is reviewed with the consulting psychiatrist. And so I'm one of those psychiatrists, and every week I meet with my behavioral health managers, and we run their cases, and we discuss sort of what is the clinical picture, what would be of most benefit, and then based on our discussion, I will make recommendations for medications, for various types of therapeutic interventions, and that patient will stay on the caseload for anywhere from 3 to 6 months, with the behavioral health manager continuing to work with them. So we've noticed that some clinics, and it just depends on the community and the needs of the patients in that community, some patients do better with a PCBH model, which is psychologically oriented rather than psychiatrically oriented. So collaborative is rooted in the practice of psychiatry, doing the consultation with the behavioral health managers. PCBH, on the other hand, is supported mainly by psychologists who do therapy and don't prescribe.
Okay.
So they are managing a cadre of, again, licensed clinical social workers or LPCCs, licensed professional counselors, who are engaging with PCPs and their patients, typically at point of care, and providing early interventions for mild to moderate level of disease. Now, there are some PCBH models that go beyond that and start involving themselves in prevention. We have one of those models. Specifically, it's called Healthy Steps within a pediatric setting, finding that patients seem to engage with the PCBH model a bit more and a bit more consistently than they do with collaborative care. So we found that works there. So, I think, depending on the culture of your practice, the needs of your community, of your patients, and the resources within that community, it really does go a long way to informing which kind of model you want to implement in a practice. I think it's worth sort of studying that and really sort of looking at your practice and preparing your practice for the kind of intervention you want to give.
That's in the case of university hospitals. That is a decision that is made at the practice level, not at a central administrative level.
So on the adult side, in the primary care institute, they make it as sort of a systems level. So leadership sort of looks at the overall needs of all the practices in Northeast Ohio, and they have determined that collaborative care really is the most appropriate form of integrated care to meet patient needs. And so currently we have a team of 15 behavioral health managers and 6 psychiatrists who provide care and consultation for 18 practices. It's been successful enough that leadership is very pleased with our outcomes and want to continue expanding the program. So we're really fortunate in that sense.
Within practices that use the collaborative care model, are there workflow issues, billing issues? Do you ever run into challenges of how that works?
Sure. There are always going to be, challenges, which is why really sort of doing a survey of practice readiness is really important.
Mm-hmm.
So I think, you bring up billing. One of the biggest challenges with collaborative care, at least in the state of Ohio, is that Ohio Medicaid still does not cover the collaborative care codes. Luckily, ever since Medicare started reimbursing these codes back in 2017, most commercial insurances have jumped onto the bandwagon and are also now covering those codes. There are other states where Medicaid does cover these collaborative care codes. But we've been really sort of working hard in our state to turn these on. We are still working. And I think we're making progress. We haven't quite moved the needle beyond where we need, but we're getting there. I think, there are also logistical issues in that a behavioral health manager needs an office. They're seeing patients, they're providing a clinical service, and we know that primary care office real estate is really prime.
Mm-hmm.
And so sometimes it's difficult if there is no space for a behavioral health manager to really sort of integrate into the practice. Having said that, we have studied the impact of offering services through telemedicine, and we found that we could be just as successful providing virtual service as we would in person and on-site. So we do have a hybrid model for a lot of our practices. Most behavioral health managers are there 3 to 4 days a week and then offer virtual services maybe 1 to 2 days a week.
Are there enough psychiatrists?
That's the beauty of this. For every 4 hours of a psychiatrist's time, they cover 2 full-time behavioral health managers.
Oh, wow.
So for our numbers, like I mentioned, we have 15 behavioral health managers. That's 15 full-time employee, like FTEs, for these therapists. And to support them, we're only using 0.6 FTE total of psychiatrist time. So we can cover with a half-time psychiatrist, we are covering 18 full practices of patients. And so it's an incredible use of the psychiatrist's time. Not only that, but if the psychiatrist is able to manage from a public health sort of population health perspective, if they're able to manage these groups of patients and the number of lives in each of these practices, that frees up the psychiatrist's schedule to be able to see the more moderate to severe illness that we would not expect primary care to see. So it's a better use of my time. It allows our psychiatrists to really practice to their full sort of training potential, seeing, really serious pathology, and allowing primary care to really take care of the more mild to moderate illness. I think one of the other challenges sometimes is, some primary care providers, philosophically, they might have a disagreement with their scope of practice and feeling that they shouldn't be expected to manage mental health issues. And so, that can sometimes be challenging. And honestly, we address that with relationship. Really just working with a primary care physician or provider, taking them sort of on the journey and sort of kind of hand-holding, coaching until they start to feel comfortable. I think one of the things that you absolutely do need in any practice is a champion. You need a PCP champion within that practice to really promote this kind of care. And, as with any new intervention or service, you're going to have your early adopters and you're going to have your majority of your providers. After a while, they see that there is benefit and it can be done successfully, so then they will start joining. And then you'll have sort of the stragglers who, are not convinced until it is much later, it is established, it is working, and then they will agree to start providing the service and engaging in this way. So yeah, I think as long as you can identify that person, you've got a toehold in that practice.
All people who go into primary care, family doctors, internists, general internists, they receive training in medical school in counseling, don't they? So is it just that they, for whatever reason, don't feel comfortable providing it to their patients?
So I think you hit upon a really good point in that most family practice physicians do get some training in mental health during their residency. Mm-hmm. Internists do not get quite as much.
Okay.
So their comfort level is typically a little bit lower unless they have sort of a natural inclination or interest in mental health care. Mm-hmm. I think, too, even within the House of Medicine, unfortunately, sometimes psychiatry is not equally regarded as other subspecialties. And so, it takes a psychiatrist sort of reminding the rest of medicine that the head really is connected to the rest of the body. Right. No. I will say the younger generations, the generations that are coming up now through training, through med schools, are much more open to this, have a much more holistic view of health than past generations.
Interesting.
But it's still a struggle. And so, but when you mention that, they will consider and they'll think about it. And then I will also tell them, look, for me personally, my next new patient appointment is not for 3 months. So we can either get your patient started on treatment and start alleviating the suffering they're experiencing now, or you can make them wait 3 months to see me for care that you could provide yourself. So I think sometimes when you sort of present the bigger picture, it's just the reality of our really sort of critically low workforce and the shortage we experience is one of the reasons that we have programs like this. Otherwise, people will not get the care that they need.
That's a very creative use of psychiatrists' time.
Well, we have to be good stewards. We've got really limited resources, and we have to be mindful. I think, with proper coaching and support and guidance, absolutely they can do it. I think it's just a matter of comfort and a matter of feeling like they have the skill and the competence to do that.
Are there any kind of protocols or standards for when a PCP needs to hand a patient off to a mental health professional?
One of the ways that we identify patients who probably need mental health services is by implementing universal screening in our primary care offices. So all patients should be screened for depression at least once a year, like at their checkup, as well as, if it comes up, anxiety. But so we have universal screening, again, using population and public health approaches to managing these. But at the same time, patients who organically bring up issues during any kind of office visit, their PCP can absolutely come to the behavioral health manager and discuss the patient and determine, is this a good referral for collaborative care? And if so, could you take this patient on? I will say if there are patients who are more severe or who have more complex needs than what we could provide within collaborative care, we actually still take them because we can provide bridge services while we are coordinating their appointment with other outside resources to get them into the most appropriate care setting that they need.
Talk a little bit about how behavioral health integration in primary care can contribute to health equity.
I think it's a great question. A lot of patients, they can engage with their PCP. However, sometimes it's much harder to engage, with other therapists and other providers. And so limiting the number of trips that they have to take, so if transportation is an issue, allowing them to engage with a trusted provider who would be their PCP allows them to really open up. I think that's important. Looking at our Rainbow primary care practice has a very particular demographic. So it's pretty much urban, inner city. It is 90% African American. It is 88% Medicaid insured. And having mental health in-house in a center where they feel comfortable, that is already on a bus route, that they can actually access, whether in person or virtually, is a huge boon to them. And so I think in that sense, it really does take down a lot of barriers to access that particularly like that population runs into. A lot of our practices are also sort of farther out of the greater Cleveland area. And being able to go to their local practice rather than having to drive into, Cleveland Medical Center in this concrete jungle of confusion and, an area that they're unfamiliar with, is much more accessible to them than being able to just go down the street to their local PCP and getting their care there. So I think that is really helpful. The other thing, too, is that collaborative care, it is billed through the PCP. And so it's not necessarily a specialist's copay. So if a insurance states that their collaborative care reimbursement is to include patients paying a copay, they still pay the primary care copay rate. They do not pay a specialist copay rate. Some insurances don't expect a copay to be paid for collaborative. That's not part of their reimbursement model. And so some patients get their care without having to pay anything if their insurance covers it.
That can make a big difference.
Huge,
yeah.
Huge. Especially, if you're going to see a therapist, let's say once a week, once every other week, and you see your psychiatrist once every 1 to 3 months, depending on how you're doing, that's a big savings, especially if you have a really high sort of deductible. That's enormous. So I think on lots of different levels, collaborative care really does address issues with equity.
Well, I think that pretty much covers what I wanted to ask about. Is there anything that you feel that you thought we were going to cover that I didn't ask about, or any other aspects of this that I should be looking at?
No, there's really nothing else, I don't think. I think the biggest thing really is just trying to get the sustainability situated within Ohio. That would be huge.
And by that you mean Medicaid coverage?
Yeah.
Okay.
Yeah, right. Especially since, in the Cleveland area, 50% of the kids live below the poverty line, which is like the highest in the country. So the majority of our children are on Medicaid. We know this model is successful in a pediatric setting. Why aren't we covering it? The typical child, they have a mental health illness. Studies have shown that for many kids, it is 8 to 10 years before they come to medical attention for a mental health issue. That is 8 to 10 years of psychological and mental development that goes unchecked, that continues to impact their functioning, to impair their ability to reach their potential, and then continues into adulthood. Why? There's no reason for that. So the other thing is that, I would say of the kids that actually come to medical attention, I think the statistic is 50% of children with mental health actually come to medical attention and get a referral. Of the 50% that get a referral, only half of those ever even make it to their appointment. And so why are we creating all these other barriers for them to get access to the care that they really do need and they deserve? So, to me, this is just, I've been working on this for 7 years. So it is, a big issue for me, especially because these are the people that you're going to be spending healthcare dollars on in 20 years. So do you want to invest in them now when the cost is manageable, or later on when they are needing higher levels of care, possibly having legal involvement because of their mental health issues, impairing their ability to attend school, to hold jobs, to maintain relationships? Like, it is the impairment that comes.
Or just holding them back from realizing their fullest potential.
Exactly. So Yeah.
Well, you've convinced me.
Well, it takes convincing of everyone else. I mean, even, like I said, even within the house of medicine, it can be challenging. I have pediatric residents come and say, well, you know what, I'm going into cardiology, so I'm not really even going to be doing primary care. And my response is, well, that's interesting. Did you know that 20% of DeGeorge patients have autism? Say, what? And so, or like I'll have trainees going into pediatric neurology. I'm like, oh, I don't need to know that. Oh, well, that's interesting. Did you know 20% of tuberous sclerosis patients have this, that, and the other? And they're shocked. And so you can't stick your head in the sand about this anymore.
All right. Well, thanks very much, ladies. It's been very helpful.
Thanks for listening. You can subscribe to our podcasts on Apple Podcasts, Google Podcasts, Stitcher, and Spotify. And when you do, please leave a review. You can find previous podcast episodes on our website, medicaleconomics.com, under the Media tab. We welcome your comments and suggestions for future podcast topics. You can email these to us at medec@mjhlifesciences.com. And while visiting our website, be sure to check out the latest news about the business of healthcare and explore the many other resources you'll find there. We hope you'll listen next month for a new episode of Off the Chart with Medical Economics.